So we'll move on to the next session, but before we go to the next session, Dr. Niladri has a quick announcement to make regarding the quiz session, and then we'll move on to the next session, which is on AKI in tropics. Dr. Sanjukta Poddar will be the speaker. She is assistant professor in the Division of Pediatric Nephrology in ICH Kolkata. And to chair the session, I would request Dr. Rohit Bhomik, sir. He is associate professor in the Department of Pediatrics and pediatric intensivist in AIIMS Kalyani. And Dr. Aditi Das, she is assistant professor in the Department of Pediatrics and also a pediatric nephrologist in AIIMS Kalyani.
Okay, regarding the PG quiz, as it was planned, it was supposed to be on Mentimeter platform, but that would need a robust signal. But we have noticed that many of us are not having a very good signal intensity in this hall itself. So we have just changed that mode. We'll be doing it offline. We'll be showing you all the questions as a PPT mode, and you'll be given a cheats, and then you can write down the answers, and we'll collect from that. Okay. So so to summarize, the mode of the quiz will not be online; it will be offline, and rest of the details will be shown during the quiz time. Okay. Thank you.
Good afternoon. So I'm Dr. Sanjukta. I'm presenting the acute kidney injury in tropics. So you must be knowing what are the tropics. So tropics are the area 23 degree above and below the equator between the Tropic of Cancer and Tropic of Capricorn. So why are we specifically talking about acute kidney injury in this specific part of the world? So because of the different tropical environment, these tropics get our direct sun rays in most of the part of the year, along with a very heavy rainfall, which is responsible for a growth of different kind of flora and fauna. It promotes the survival of microorganisms and also a large number of insects and snakes, which can lead to envenomation. And this tropical environment is associated with certain predisposing factors like low socioeconomic status, poor living conditions, and overcrowding. Most of the countries which are lying in the tropical zone, they are overcrowded. As per the land area, it is only 23%, but 58% of the total world population are living in the tropical region. And most of the countries are either lower income or lower middle income countries. So endemic malnutrition, relative hypovolemia, and even G6PD deficiency in certain ethnic backgrounds are associated with acute kidney injury in these tropical countries. Often it has been seen that the tropical countries have a younger age of onset of AKI, often late presentation, and the healthcare services are not that easily available, scarce hospital resources, and higher mortality rate. So it is around 25 to 80% cases of AKI. There is a large variation depending on the part of the tropical country. Now coming here to a study by ISN, 0 by 25. This is a global snapshot study where they have seen, they have aimed to taken an initiative to prevent all avoidable deaths from AKI across the world by 2025. There they have mainly targeted the tropical countries or the LMIC countries with increasing the evidence base, improving awareness about AKI, and developing interventions that will improve detection and care of AKI in low resource settings. Regarding the causes of AKI, the temperate zone has a complete different spectrum from the tropical area. The hospital-acquired AKI, trauma, industrial accidents, cardiogenic shock, drug intoxication, and post-renal transplantation, these are more common causes of AKI in the temperate zone. While in the tropical areas, it is mostly the community-acquired infections, toxins, chemical agents, and obstetric complications and surgical complications. Regarding the causes, we face infections more commonly like malaria, leptospira, typhoid, hemorrhagic fevers like dengue, infective diarrhea because of the contaminated surface water. So all these are together known as the fever with AKI syndrome. And HIV is in rising trend in this, like in the African subcontinent mainly. For certain plant toxins and mushrooms, animal poisonings like snake bite, wasp, bee, scorpion, spider, and chemical agents like copper sulfate and ethylene glycol, G6PD deficiency, and certain other surgical and obstetric causes are also there. The pathology is either mostly acute tubular necrosis, in some cases it may be acute interstitial nephritis, post-infectious GN, hemolytic uremic syndrome, prerenal injury due to hypovolemia, and hepatorenal syndrome. It is from the ISN 0/25 global snapshot only. They have this report where they have specifically talked about AKI in children, and if you can see this table, the age in this study, the higher income countries, the age group of presentation of AKI is much on higher side, while it is lower in the LMIC country. And another important thing is community acquired AKI is almost double of that of the higher income countries. Second thing to mention is dehydration, hypotension, and shock. These things are more important contributing factors of AKI in the LMIC country than the higher income countries. Now, regarding the diarrhea and dysentery, AKI is, these are very important causes of AKI in the children for the developing countries because of the inadequate access to primary healthcare services and contaminated surface water. Dehydration often leads to prerenal injury, and sometimes if prolonged, which often happens because of the delayed presentation and healthcare services, so ATN can develop, and diarrhea associated AGUS following enterohemorrhagic Escherichia coli, Shigella dysentery can happen. So ORS is a very important solution, and for this, regarding this, need to know this person, Dr. Santosh, a pediatrician from Hyderabad, who has been fighting for the 8 long years to prove that any sweetened drink that that comes into the market by the name of ORS may not be ORS. So it has been banned from FSSAI that any sweetened drink that does not follow the WHO ORS composition guidelines cannot be named as ORS. Regarding infections, malaria, we are a malaria endemic zone. 20% of the malaria cases may develop AKI, and often it is associated with multi-organ failure. Cytopathic hypoxia may be there because of the reduced ATP synthesis. Another important thing is cytoadherence, where the microcirculation is clogged because of the parasite-invaded erythrocytes. It may lead to hemolysis and pigment nephropathy. So volume depletion, sepsis, and nephrotoxic medications, because the antimalarial drugs, as we all know, quinines and artemisins, both the group are nephrotoxic, and if there is a underlying G6PD deficiency, the quinine group of drugs can lead to hemolysis also, are important predisposing factors. The renal pathology is mostly ATN, though in malaria it is targeting the distal tubules, but most other infections the proximal tubules are affected. Interstitial nephritis and glomerulonephritis are other pathologies. Mortality can be really high if not treated on time, intervention on time. Electrolyte imbalance, hypoglycemia, and acid-base imbalance are the complications. And one thing to mention, peritoneal dialysis in these children may not be that helpful because of the clogging of the peritoneal microcirculation by the infected erythrocytes because of that cytoadherence property. Leptospirosis is another infection. This is a zoonosis which occurs, which leads to AKI in 40 to 60% cases. There are two phases of the disease. One is the infective phase, another is the immunological phase, and mostly this zoonosis occurs in the immunological phase. Hemodynamic instability, cytokine release, and direct toxicity of the leptospira can lead to AKI. Wells syndrome is a condition where there is a severe immunological reaction and multi-organ failure in leptospirosis. One important point is hypokalemia and hypomagnesemia develops in case of leptospirosis in spite of the AKI because of potassium and magnesium wasting in the urine. In most of the AKI we have seen hyperkalemia, but leptospirosis, even if it's a AKI, there may be hypokalemia. Pathologically, ATN is the most common. Rarely there can be interstitial nephritis or AGUS. Regarding the leptospira-induced AGUS, here it is a case report from Institute of Child Health, where an 11-year-old boy presented with fever, pallor, along with jaundice and AKI. On further investigation, there was thrombocytopenia, and the peripheral smear was showing 4% cystocytes, along with raised LDH and reticulocyte count, all suggestive of hemolytic anemia. C3 was low, and the child was having AKI. So AGUS was diagnosed, and anti-savage antibody titer, genetic panel for atypical AGUS all were negative. Only leptospira IgM antibody came positive for that child. So this was a Leptospira induced AGUS that was confirmed by renal biopsy where it showed thrombotic microangiopathy. So only treating the infection treated the child, and the child had the AKI and the AGUS parameters, they improved over the next 7 to 10 days. HIV has been a rising trend where there are 20 to 48% AKI in the sub-Saharan Africa because of HIV. The most commonly it is because of IRIS, where there is a severe immunological reaction following introduction of the antiretroviral drugs. Sometimes it is the antiretroviral drugs themselves causing crystalluria and nephrolithiasis and AKI. Retroperitoneal fibrosis and bladder dysfunction can happen as a side effect of these antiretroviral drugs. Very high viral overload, low CD4 count, hepatitis C co-infection, diabetes, black race and male gender are other risk factors. Now coming to the hemorrhagic fever, as we all know about dengue. So dengue hemorrhagic fever can develop AKI. In 60% cases of dengue fever can develop some amount of AKI. Mostly non-oliguric and recover spontaneously, but there are certain severe cases where there may be a multi-organ failure, oliguric renal failure and requiring RRT. Now coming to the snake envenomation. So this is in our country, there are different types of snake which can cause acute kidney injury. Most important are the vipers, which are mostly hematotoxic and which cause hemolysis, thrombotic microangiopathy and pigment nephropathy. Myotoxic snakes can cause rhabdomyolysis and myoglobinuria leading to ATN. So all pathologically they mostly cause ATN, but there is a very severe variety where there is acute cortical necrosis because of snake envenomation. So acute cortical necrosis, often the recovery may not be complete. So there may be some amount of residual kidney injury. Acute interstitial nephritis and thrombotic microangiopathy are the other types of pathology. Antivenom is the drug of choice and sometimes requires RRT also. So coming to this is the famous tree of life from Avatar. So as we have seen in the movie also that nature gives us everything good and the life and its healing, it can be easy, but when the nature, when we take the nature's gift. But we nephrologists, we are taking this with some pinch of salt. Nature's cure or kidney curse. So that is a paper by Dr. Vivekanand Jha, where they have talked about traditional indigenous medicines. So there are certain medications which are derived from local flora and fauna, and they can be, instead of helping us, they can be detrimental to the kidneys. So traditional herbs and heavy metals are also part of this. 35% of the AKI are attributed to folk remedies in developing countries. That is quite high, and they mostly target the proximal tubules. They often present in different types of acute kidney injury. Sometimes they may cause rhabdomyolysis, Fanconi syndrome, that is a type of tubular injury, nephrolithiasis and pigment nephropathy. So there are different types of drugs, the folk remedies which are causing AKI. So among them, one or two needs to be mentioned. One is the very important drug is the Chinese herb. This medication was used towards the end of the last decade as a part of weight control, so reduction of weight for obesity control. But after a few days, it has been seen that many of these patients started to present to the OPD to the emergency with periodic paralysis. So actually this drug acted on the proximal tubules and causes a condition like Fanconi syndrome. So these patients developed hypokalemia, hypophosphatemia, glycosuria and all these things, hypoglycemia. There is another fruit called star fruit which can cause nephrolithiasis. There is a Zulu tribe who in Africa who are using enema as a part of folk remedy, as a part of tradition thrice a week. And following this, they develop severe electrolyte imbalance and even AKI. Then noni juice is there, which was used at a time as a part of rheumatological treatment and also to boost up the immunity. It has been seen that they cause hyperkalemia. And there are hundreds of like this. One heavy metal needs to be mentioned is the copper sulfate. So that there is this holy water which used to contain copper sulfate as that coloring agent, blue coloring agent, bluish discoloration. It looks very pure and blue water, but actually it is toxin, and this copper sulfate, it causes acute kidney injury. Here is a case report from again from ICH only. It was presented by one of our PGTs. So one a 7 years old child presented to us after ingestion of raw fish bile as a part of folk remedy, and the child presented with AKI along with a liver injury. So we had to do hemodialysis for that child also for 4 to 5 sessions, but the child improved over the next 7 to 10 days, and achieved complete he came out completely of the acute kidney injury over the next 10 days. So this is also a part of this regional folk remedies which can lead to, which is called ichthyotherapy actually, which can lead to AKI. Now, obstetric AKI, as a pediatrician, why I'm concerned? Because there are teenage pregnancies. So, teenage pregnancy is often neglected, and they are associated with more complications like antenatal hemorrhage, abruptio placentae, uterine sepsis, illegal efforts of abortion, sometimes eclampsia and preeclampsia, and PPH. So, hemorrhage and hypovolemia, shock, sepsis, all these lead to MODS and acute tubular necrosis. And one thing to mention is acute cortical necrosis that I had already mentioned before, which is a more severe form of ATN. That can happen with either obstetric AKI or snake envenomation. So, there may not be complete recovery. So, my take-home message will be physicians should be aware of the cause leading to AKI in the tropics, because they are very much different from the developed countries. Diarrhea and dehydrations is still the leading cause and needs to be addressed very, very fast without much delay. Non-oliguric AKI, which can be present, is often missed. Monitoring of the renal functions, especially for those on nephrotoxic medication, which we often miss, should be done meticulously. Early referral for patients with evolving AKI. So you have to know when you need to refer the child to a higher center, and early initiation of RRT has overall lesser mortality and better prognosis. Thank you.
So you are asking about the best of them.
Thank you very much. If you can proceed to the felicitation counter where Dr. Sakil Akhtar will be felicitating you. So some of our external faculties will be leaving to catch the flight. So because of that, we have preponed the problem-based learning session, and that will be interesting. So we would like you to arrange in 4 groups. So Deblina will tell the groups, right?
So delegates, this is basically for delegates. We'll be giving you some case scenarios and asking questions, and the delegates will have to answer. And there will be 3-4 faculties per group who will be giving them hints in case they are not able to answer. So I'll request the delegates to be seated into 4 groups. Group A, this is group A. Shanjukta? This is group A. So this is group A. Achha, so this is group A, group B, then that is group C, and that is group D. And I would request the faculties to kindly move to the tables. Group A, the faculties are Dr. Sunita. Kindly come to this table, ma'am. Dr. Aditi. And Agni sir is already here. The faculties for group B are Dr. Sukanya ma'am, Dr. Rohit and Joyati ma'am. Ma'am, please move to that table. I'm going. This is group A. Sukanya ma'am, you have to move to group B. And the faculties for group C are Dr. Shubal sir, Dr. Dibyendu Rai Chaudhuri sir, to that table you have to go, and Dr. Madiha.
So I would ask you all to come forward a bit. Best thing will be come forward.
Dr. Madiha is here.
Yeah, so I would ask you all to come forward a bit. Try to like these 4 tables, something like that. The most of the questions and questions were being done from the morning by the faculties. Dr. Agnisekhar Saha and rest. So now is the time for the trainee to be involved, and we will be expecting the answers from them. So have you done the groups?
And faculties for Group D are Dr. Rana, Dr. Swardeem, and Dr. Priyanka. So I'll repeat the faculties for the tables once again. So faculty for Group A are Dr. Aditi, Dr. Sunita, and Dr. Agni sir. Faculties for Group B are Dr. Sukanya ma'am, Dr. Rohit, and Dr. Jayati ma'am. Faculties for Table C are Dr. Shubal sir, Dr. Dibyendu Rai Chaudhuri sir, and Dr. Madiha. And faculties for Group D are Dr. Rana, Dr. Swarneem, and Dr. Priyanka.
Okay, so we will start.
Dr. Yasu sir is here. Sir, please
So
be seated on table
the
X.
group which hasn't got any faculty, it is their bad luck. So which is group A? Group A. Okay. Both of it. Group A. Group B. Group B. Okay. Group C. Group D. Okay. So we start here. So a 9-month-old girl seen in OPD at 4 p.m. febrile for 3 days. Parent concerned about no wet nappies since 8 p.m. yesterday. So what are the next steps? And I'll give you about 1 minute, full 1 minute to think about it. And this is for obviously group A. So if all the groups will require 1 mic each. Ready? My clock runs fast, so 1 minute is over.
Check. Low.
So who is going to answer? If nobody,
Sir, I would first ensure that the history is
very good. So he said that he will take a proper history. What history? You said history, right? So history ta ki nibi? What history?
about the feeding and
Okay.
whether the parent is observed rightly that when the last urine has passed.
Yeah, they were almost quite sure about the They are very, like the first child, they are very, very worried. Anything else?
Any history of ongoing loss, diarrhea or vomiting?
No. Huh? Hydration stresses. So what we wanted to get through you is you will go to the basic, the history and examination. So we do that, and this was the history. Not feeding well, just one vomit, and the child is febrile, lethargic, peripheries are cool, CRT 3 seconds, heart rate 130, and some maculopapular blanching rashes. So what next? So this is for please এটা কি হলো ওদের মুখ দেখানো দরকার নেই this will do. Yeah. So what next? So I have given you the parameters.
What next? Access karo. Bolo.
Sir, A, B, C, air breathing, circulation and hydration we will check for the
Yeah. So everything is everything is given there.
get
Most of the things. Respiratory rate maybe not given. It was about 54. Okay, your 1 minute is up. Who is going to answer?
Sir, first we have to
No,
check.
now is group B.
Will proceed airway breathing circulation and disability wise.
And so he says that he will do A, B, C. Okay, and
And
what about
whether
so for the circulation? What will you do?
whether the patient is in compensated shock. Looks like
So he says that the patient is in compensated shock. I don't know why he said 9-month-old. Okay, okay. Compensated. Why do you say compensated shock?
because BP is maintained, heart rate is
Okay,
slightly
so
higher side,
is it
capillary
compensated
periodine
shock? Yes.
borderline, and periphery is full.
তোর ইয়ে আছে তো মাইক আছে তো এখানে চলে
BP normal at 9 months of age.
So BP is 70/54. Devlina is saying that for 9 months is a systolic pressure of 70. That's what you'd be expecting.
70 to 74 systolic.
Is it acceptable?
Check.
It's more than 5th centile.
Around 5th centile, the BP is 72/50 is 5th centile with the periphery school and low perfusion. So child is in a
So
life-threatening
you're saying
condition.
that it's compensated shock.
Compensated shock. We'll
Okay.
optimize the.
So now what? What would you do?
We'll give an IV access.
IV access. Good. So you would put in an IV access, and while putting in an IV access, what would you do?
Fluid resuscitation. First of all, we'll take electrolytes,
We will send some bloods and give some volume.
blood gas,
Okay.
electrolytes.
So if the other group or any of the senior faculties don't agree with any of the statement, you can just put your hands up.
We can go for blood culture and first dose of antibiotic.
Okay, yeah. So we were, so IV cannula was done and culture sent, blood gas given there, and bolus given. At 2 hours, the child had received about 60 ml per kilo of blood, of fluid. The CRP is still on the higher side. Respiratory distress increasing, 5 ml of urine only passed, blood gas worsening. So now 60 ml per kilo reached, the child got intubated and ventilated. Everyone agrees to this? The intensivist and the Sumanta doesn't agree.
Mike.
Okay, Sumanta was saying that have we catheterized the child or not? The child was catheterized. Any heart failure sign, any gallop or not? So with 60 ml per kilo, so you have to be looking at for the signs of gallop, etc. There were no, yeah, but the child was having so distress, so was intubated and ventilated.
Focus.
So Sumanta was saying that before giving, so you give the first bolus, but then before giving the bolus, you should be assessing whether the child is overloaded or not. Why so? Group B only.
We'd be looking for B lines in lung ultrasound, IVC collapsibility, cardiogenic shock, ejection fraction we'll be looking for.
So where are you working?
AIMS Kalyani.
AIMS Kalyani has a ultrasound machine in the emergency.
Adult emergency has. So matlab we are in vicinity, so we can take.
Okay, most of us are unfortunately not working in AIMS Kalyani, and we don't have an ultrasound machine in the emergency. Not even a corporate hospital like Apollo or Manipal.
So we can look for hepatomegaly, Krebs, puffy eyes.
Okay, so we should be, so the message is like as per that study done from published in NEJM and done from Africa, that lot of fluid is not a good thing. Okay, but there was still it was like there might have been some hepatomegaly, some rails maybe, but since the child was very sick, not improving, they went with the intubation and ventilation, right? We move on. Okay. So we have already discussed this, no? Volume of fluids for resuscitation and type of resuscitation fluid. I'll go to the team C. Team C, where's team C? Okay. No, A হয়ে গেল, B হয়ে গেল, C. So team C, what you have to tell us in 1 minute is comment on the volume of fluid, like what is your advice, how much volume of fluid resuscitation should be given and what type of fluid should be given.
Initially, we should start with a 10 ml per kg of bolus, and crystalloids will be preferred over colloids. If possible, a balanced salt solution would be better than 0.9% sodium chloride.
Okay, so she is saying that in a child in shock, you start with 10 ml per kilo and then reassess, and she is saying that she would prefer a crystalloid and she would prefer a balanced solution for resuscitation. Everybody agrees to that? All intensivists, all nephrologists?
No, I think two part. Of course, too much fluid is not good. And here, a patient has just come. Your primary worry about giving fluids is it a patient with cardiogenic shock? And if it is so, giving too much fluid can lead to disaster. Now, a cardiogenic shock patient will not look dehydrated. And this kid has got very definite reason for dehydration. So I think in this kid, just holding 10 and not giving 20, I think we are overdoing that, fluid. Yeah,
So
absolutely, be cautious.
About the volume, what you are saying?
In this kid, my fast bolus, I'll give 20. Definitely 20.
So,
Maybe I will be a bit cautious.
We can maybe agree that we usually give 20, but then it all depends upon how the kid is, and then you can start with 10. As long as you are you are reassessing within half an hour, I think we should be fine. The point, and this is a very important, because when I started my training in UK, I received a child, I had given 10 ml per kilo, and I was called up that why did you give 10 ml per kilo? And then I said that no, I did go and reassess within 10-15 minutes, because I was worried whether the child is already in heart failure. So as long as you reassess, I think you are okay. So the volume is 10 to 20 ml per kilo, okay. And what about the type of the fluid?
And again, I mean, balanced fluid up front, difficult. It costs more, significantly more. So maybe if you do a gas and your chloride is already up, and you are acidotic, then balanced fluid up front maybe. But in most cases, normal saline still should hold true. And again, cost should be a good concern. I mean, later on maybe.
Does everyone agrees with this?
Sir,
Apart from that, valence salt, what sir has said, the cost and availability, still the guideline says it is a normal saline. And on top of that, it is anuric child. So giving a fluid, anything with potassium containing fluid, please take a pinch of salt.
So
the balanced salt contains potassium, which is almost equivalent to RL.
Potassium in it.
And this child already has hyperkalemia. So balanced salt contains around 5 milliequivalent per liter of potassium.
So I think if all the intensivists and the nephrologists agree, then the take-home message can be that initial it is still normal saline. Although just recently, as you must be knowing, that's why you are quoting that there was this RCT, but I think it was in the adult, no?
No, in pediatric.
In pediatric, where they showed that a balanced solution is a good option.
Is questionable that, and in this,
no, that RCT.
Yeah, it is there in the pediatric also it is there. But no fluid is superior to, even then the meta-analysis in adult also it is came. But in this patient who is anuric potassium containing fluid upfront.
Okay,
no.
can the expert or even you can say in what are the situations where maybe some other sort of maintenance fluid is normally we go for half DNS, something like that. But in resuscitation, any other situation where we can go for anything else, or DNS. But what are the situations? Are there any situations like this, like in sepsis, maybe albumin is better, is it?
No, sir. No, hypotonic solutions are not at all.
No, albumin.
Albumin, there is a particular indication, sir.
Huh.
They are like
What are the
dengue, only dengue. Any nephrotic syndrome if hypoalbuminemia is there. There are specific indications for albumin. Otherwise, crystalloid and normal saline to start.
Creatinine is on the higher side, giving albumin
Not,
might
not in this situation, but any other situation in where you would be using
A kid with decay, I mean, you can argue that kid comes with decay, pretty bad, dry, and in decay you often get a lot of hyperchloremic acidosis. So that may be a case for using balanced solution upfront. That is possibly the only thing I can think of.
Okay, so overall message is that still crystalloid, and nowadays we are not using hypotonic, we are using isotonic. So with all that, at 8 hours the child still ventilated on high setting, MAP of 55/60, urine output only 10 mLs. What next? And it goes to team C.
So the map is around 50th centile for this age. So now what next would you like to do? Which table are we
Team C, team C.
on?
Sorry, D, no? A, B, C, D. Yeah, team D. It seems I'm bad with A, B, C, D also. Ready? Team D? What next? We don't have, we can't give much time, so.
Hello. Sir, we should assess the fluid overload status. Is if almost 10% or more than 10% fluid is already overloaded, then we should think of diuretic challenge, and if further plan will be according to the response.
So now the child is in PICU. So how do you assess the intravascular volume?
Sir, in PICU, the clinical parameters, and then the daily weight status, intake output chart, and some bedside focus, IVC status, and some lab parameters. This all will guide me to assess the fluid
So
status.
Devlina has and me also, like we have put up all this. Which of these do you think will be useful? Let us start from the FENA and FEVRIA. Will that be useful?
That is also useful, but mostly focus and IVC assessment.
Why? Why not FENA and FEVRIA?
It's it will take time and volume overload. FENA.
So first of all, it will take time, and secondly, we have already given so much of volume,
sodium
etc.
No, but we have to keep in mind that it is very often very difficult to ascertain with one particular parameter. So you may have to do everything and then you take an.
Yeah, but then I am arguing that we cannot wait for FENA and FEVRIA.
No, that is true. But suppose if it's a child who is having massive ascites, suppose it's a child with dengue who has developed capillary leak, having massive ascites. In that case, will your IVC assessment be reliable? Because of the tense ascites, it may be falsely collapsible. But this child is.
So as usual, you have to have the full picture.
Combined clinical and
What about the
lab
CBP
parameters.
measurement?
Yeah.
Not
In
not
this
regularly
age group,
done?
a child, it's a 9 months old, CVP measurement could not be done. Not be reliable.
It can be done, but it is difficult.
It is
Can be
difficult.
done, but again, as Devlina was saying, that if it is a ascites, that will also
will be
interfere with
false.
Yeah,
the.
so if it's a right heart failure having like pericardial effusion tamponade, in that case also your CVP assessment may be erroneous. So in any child this critically ill, you should not rely on one particular parameter to take a decision. So it's better that we try to take out as much information as possible and then take a decision. So we usually what we do the IVC assessment, and we talk to the lab in cases where we feel that IVC assessment may not be reliable. In that case, we will tell the lab to will do the phenylketonuria, but again, that becomes difficult if the child is completely anuric. So in that case, you may not be able to do it. So often it's very difficult.
And here definitely like your lung B lines and all that will be useful. What else will be useful here? You said that you will assess the intravascular volume. What else do you want to know? Okay, we'll come to that, but you were unable to answer that. What else? Huh? The child was hypovolemic. Hypovolemic, how do I know dehydration? It was, turgor was not raised. We are, the weight wise, the family hasn't done any weight recently. There was not that much. The turgor was not raised. The
Like
cap refill.
Clinically, by clinical examination, the child looked euvolemic. The child did not have any edema when the child presented to us.
Hypovolemic. Initially?
Clinically, he was looking euvolemic, but when we did all these assessments, we like clinically it was.
No, he was hypovolemic because his capillary refill was
3
prolonged.
seconds.
But so hypotension is different from hypovolemia.
He was okay, but his capillary refill was prolonged.
Yes. So the child was in shock. Partly it was because of pre-renal factors, and partly because the child was also in septic shock.
Yeah. Volume wise, we don't know at the initial. But so I will skip this because we nephrologists really want to discuss a lot about FENA and phaeria. But actually, in this sort of a situation, it's not that useful. Even in ICH, where we get a urine sodium a little faster, but in corporate hospital like Apollo, Manipal, in Manipal they give a urinary sodium next day.
Next day.
So how is it useful? So we will skip that.
And it's a very dynamic situation. You give one volume, it changes, but your FENA is so many hours before.
But we will assume that on POCUS, the child didn't look that much of overloaded. So they gave one more volume, and then what we normally do, so we have tried to make it practical, that what we do in our day-to-day practice. And I always tell the intensivist with whom I work with, like you people say a lot of things, but at the end, even in Apollo, if you want to get an ultrasound scan, you have to, like the Apollo PISU doesn't have their own ultrasound scan. So you have to bring from somewhere else. The Manipal PISU doesn't have, ICH one has, but so it is a variable thing. So now we come to 36 hours. Now the child is insensible and output. What next? So we go back to team A. Team A is, yeah, what next? Ready? Pardon? No? That's why I'm asking what next. Do you want to try it? Previously, no, it wasn't tried. The consultant who at that phase had never heard about this furosemide challenge test. So what next?
Sir, Lasix challenge test, 1 mg per kg.
So you'd go for a furosemide challenge test. Okay. What are you looking here? My first question will be: is this child now in AKI? Why?
This urine output is reduced to 0.3 ml. It's in stage 3 AKI.
And what else is bad here? One is the
Creatinine has gone up and potassium is also high.
creatinine is 0.7. 0.7 is hardly anything. No? 0.43. But only one group.
So it has gone up from 0.4 to 0.72, and potassium is 5.9.
So why is 0.7 important, you said?
More than 50% increase within 24 hours.
Almost 100%.
So what he is trying to say is that there has been that increase, like we heard in the morning, no, like even a 0.3 increase over 48 hours is AKI. So the child is AKI. We should be involved, right? Nephrologist should be involved. Although Agni is thinking in other way, but maybe nephrologist should be involved. And anything else? So one, you said that the creatinine is up. What else? You said the urine output is down. What else?
Fluid overload.
Volume. So you should be asking what is the fluid overload. Okay. Take to. Deblina? So the child is falling into stage 3 AKI. So that is very interesting, no? Like for those who are uninitiated, that because the child is now 0.3 ml per kilo per hour for 24 hours. Huh? 36 hours. 36 hours. Like yeah, it has fallen further. No. Okay. So let us assume it was 36 hours now. So it is like even with just a norm, like a slight jump in creatinine, you can still have a stage 3 AKI. Because what you have to remember is that of the two criteria, whichever is worse, you stage your AKI with that. So that was the message that we were trying to give.
We'll come to this later. This is actually stage 3 AKI because there is another thing, initiation of renal replacement therapy. So this child is actually, we'll discuss in the subsequent slides, lot of fluid overload. So he'll be needing KRT right now.
And this is the, like I always say, people may disagree, but we speak of lot of things, but I think this is the one of the only intervention that has been or the only solid thing that has come out in the last 10 years, that fluid overload is not good. Other things are still in the pipeline, including the NGAL, etc. But fluid overload is bad. So the child is how much percentage?
So I'll just go back to the previous slide. So how to calculate the fluid overload percentage and how much fluid overload does this child have? Can anybody calculate? So this child was 9 kg when the child presented, was not having any evidence of hypervolemia. The child was not edematous when the child presented.
This is for B.
So table B has to answer what is the fluid overload percentage in this child. So we have provided all the information needed. Weight was 9 kg at admission. And at admission, the child did not have any overt manifestations like overt dehydration. Yes, 17%. Yes, it is 17%.
The answer was given by team A. Team B is just like me, bad in mathematics.
I've got a question here. I don't know the answer to that question. Suppose this kid comes, Deblina said this kid looks euvolemic. So that, but suppose I've got a kid who looks dehydrated when he comes.
So for the
do you use the same formula?
So that's why, sir, fluid overload and positive fluid balance is different. We will call it fluid overload
if the
when
kid
a
is
child
looks dehydrated?
No, that's what, sir. If the child is having positive fluid balance plus edema, pulmonary edema or peripheral edema, then we should call it fluid overload.
And also,
because this may
for the purpose of calculation, we don't include the resuscitation fluid. It is after the resuscitation fluid.
And we have to take the dry weight into consideration, the optimum weight into consideration. So that denominator weight in kg is actually the actual weight of the child. So because it's a very common scenario, child comes to us with suppose AG and severe dehydration, and then we give them lot of dehydration correction. So on paper it will actually show that the child is having lot of positive balance, maybe 17%, but it doesn't mean that the child is fluid over.
So next we go to the team C. About the team C, do you agree that this child needs renal replacement therapy? Number one, they have said 17% overload. So do you agree with the child needs a renal replacement therapy? And if you want to do a renal replacement therapy, what is your move? Okay, 1 second. Well, and team C, you can take this question also from Dr. Rifa, that at this stage, do you want to give a Lasix also? A furosemide challenge test, already 36 hours gone, and do you want to give a furosemide challenge test in this case? I think Dr. Ahmed particularly chose not to go to any team. So, two questions. One is that do you want to go for a furosemide challenge test in this scenario? And secondly is that if you want to start an RRT, which mode of RRT? Your time is up. So, do you want to go for furosemide challenge test in this scenario? Yes? No?
So, no, sir.
No. Okay. Do you agree? अरे बोललाम आरो 10 मिनट ना এটা তো 40 মিনিট
Already we showed Dada that we have already optimized the volume status, and despite that the child continues to be anuric.
What Deblina is saying is that they have done this focus all that. They have seen the phenaphuria. They feel initially it was pre-renal, but then even with the volume and everything, it is not still improving, right? Now it seems to be intrinsic renal. But the question remains: do you want to challenge the child with furosemide or not? Dr. Kadura, anything else? Huh? No. You want to?
Yeah, we thought no because of the blood pressure was pretty borderline, and we didn't want to drop. We didn't want to cause a vasodilation.
So no furosemide.
Would you ever use a furosemide infusion though?
Huh?
Furosemide infusion instead of a bolus.
So furosemide infusion. The child is not making any urine, so I don't think we will give a furosemide infusion. What about mode of RRT? Mode of RRT? Which one would you prefer? You don't have time. You have to answer now.
Yes, sir. Because the child is already on 2 inotropes.
Yeah, we would.
And at 50th centile on 2 inotropes.
Correct. So still we can give Lasix because the BP is maintained as of now.
I don't know. I don't
MAP is
think there
60.
is. Yes, sir, please, sir.
MAP is 60 on 2 inotropes. You're sailing pretty close to the wind, I think.
90 systolic is at 50th centile or at 10th centile or what? Systolic
MAP 60 to 65 is just about okay.
Okay,
It's around 50th centile.
50th centile, तो हम लोग तो 50th centile में तो we can give ना. The lower limit is 10th centile, the upper limit is 90th centile, median is 50th centile. So if your MAP is at 50th centile,
you want to give Lasix, right?
At least one dose of 1 milligram per kg. Lasix नहीं बच्चा. जो पहले करना चाहिए था.
So
At least we have done.
আমি তাতে করছি. So Sumanta wants to give Lasix. We can have a hand. So how many of you will give Lasix?
Why it was not given earlier?
I've already said that the child was always hypovolemic and the physician had never heard about this furosemide challenge test. But now, hands up, giving Lasix. 1, 2, 3, 4, 5. Huh? 5. Huh? 5. You will? That's fair. That's not fair. So 6. Okay, 6 was in favor of last 6, not giving last 6. So I think it is no slightly. So we leave it. We don't give last 6. Okay, because we are a democratic country. So we. Why do you want to do dialysis? Because they feel that 17% fluid overload is significant, and that's what you have told. Now they feel that I've been told from the morning that 10 to 20%, anything like that, is increased mortality. So they don't want the child to die. Give him the mic.
Because the fluid overload is very high, more than 10%, that is an indication to go for a replacement therapy.
That's what I was saying. That's what you taught them from the morning.
So I want to clarify something. So when they correlate the mortality with the fluid overload, they correlated with the max fluid overload. So the question comes to now. This patient already got the 17%. So that at this point he got the high risk of bad outcomes. Do we know if we take him down that the mortality will be better? So here is the trick thing. So what we know from the PCRRT the data showed that if you hit the high level of volume overload at 20%, 25%, you achieve the risk. So they're going down, trying to bring it down, okay? I don't know if it's gonna be helpful, but what's gonna be harmful is if this can go up. So in that case, if your ventilator is good, sorry, I missed the ventilator part.
Ventilator part is on the high ventilator settings.
Yeah, I mean that's for me an indication for dialysis if you want to improve the ventilator.
So if I can summarize it a bit more, so that we don't go home confused, because from the morning until now we are saying that fluid overload is bad. We showed this. Where is that gone? We showed this one, no? That like the higher the fluid overload, more the chances of mortality. Yeah. So we also said that anything above 10 to 20%, the chances of mortality increases significantly. Now the very person who said that is saying that maybe we can wait a bit more. So what we are trying to bring in is that you have to be pragmatic. Suppose if the child is well settled, then maybe you can delay it a bit more. Maybe you can even try a furosemide bolus. But if the child is like in our child, the ventilators are still on the high setting. So that might be itself an indication that no, fluid overload is causing some damage. If the child is in congestive cardiac failure, Sumanta was asking what is the heart status showing, then again it might be an indication for going for the RRT. Okay, so suppose in this child we want to go for an RRT, what mode of RRT would you choose?
CRT.
Okay, where are you working? Who said CRRT? So, Sakil is working in a very poor hospital, Institute of Child Health, which has recently acquired a CRRT machine, and per day 30,000 to 40,000, and on the next day usually the family comes and says that আমি আর কিছু পারছি না, I have exhausted everything and go. So, but Sakil will use CRRT, okay?
No, given the choice, the first option should be CRRT.
But you didn't
and if
say
you
that.
have the facility available, definitely CRT should be your first choice.
So,
and the person next to you is already used CRT quite a couple of times. And
modifying that, what now Sakil says that the most optimum mode of RRT may be CRRT. Does the experts agree on that, right? Dr. Kadura is also nodding his head. Yes, given the all, like if I've got everything, money is not a concern, then CRRT will be the optimum model. So Sumantra has been teaching peritoneal dialysis to everyone. So that is the conflict of interest, na bolte hai. So he is saying. So he is saying that do we have any trial proving that CRRT is better than PD?
Yes, sir. Yes, sir.
Anil, samne ja. Give a mic.
I don't know whether it's the right question to ask which modality is better, because it's comparing apples and oranges. I mean, I take the intensive care perspective. Is volume controlled or a pressure controlled ventilation? Because these are all case-based, individualized thing. So whatever is available, that needs to be given. That's one. But if you have everything available,
Shakil said,
if you have everything which is available, resource is not a limiting factor, then you give the best which you can control well. Because the problem of PD is you don't have a good control on ultrafiltration in a very hemodynamically unstable child. You have to do all these titrations. So that may not be an ideal when you have a clear, when you have everything in your access and affordability. So I think the question of which modality is better in terms of outcome may never be answered, because that situation is not something.
That's a wrong question.
Absolutely.
It's a wrong question.
Absolutely.
Yeah, so you have asked a wrong question.
I will take this. I will take this further. So even, I mean, if you look to the literature, New England Journal of Medicine, if you achieve the fluid removal appropriately, there is no advantage of any renal replacement therapy over diuretics by themselves. Okay, so the goal here is not to make the child to reach fluid overload, and when there is fluid overload, just manage it the way you can. Diuretics, PD, or CRRT, or whatever.
The comment was on fluid overload. I mean, the pediatric ADQI we're just reviewing is very clear. We should not use the term anymore fluid overload, because it confuses with the actual clinical fluid overload. So the term now used is fluid balance, of daily cumulative balance. And the Lancet, which Girish was pointing out in the systematic, they say that even that term may not be preferred, fluid accumulation, just to give a sense that it's something positive, whereas fluid balance could be negative or positive.
And every ICU worth its salt should be having this record on their ICU chart daily, that what is the current fluid accumulation, so that you can think of starting to remove the fluid. But we'll finish in next couple 2-3 minutes. Going back to my question about which mode of RRT would you use, I still stick to my question that given the choice, which mode of you have everything, which mode of RRT you use. And we have got I can't remember whether that's a randomized control or controlled, but we have got trials from Brazil where they have used a PD and compared it with CRRT, and they have found it the same. But that PD was a continuous flow peritoneal dialysis and with a high volume. Team A, and we'll maybe end here. Team A, can you say of couple of situations? Sorry, Yasu wanted to say something.
Sorry to interrupt. Just one question and 2 comments. The first question is that from any point of time, from receiving the patient to till 36 hours, if we would have done POCUS, could we have prevented the inadvertent infusion of fluids and then prevented RRT due to volume overload? This is my question. And my 2 comment is regarding the mode of RRT. We have not mentioned SLED in this. So our 5008S machine works for 23 hours out of 24. We give 1 hour test run and then we can restart the machine, and the cost of RRT by SLED machine is just 1/10 of the CRRT.
Sorry. So this is taken from 2004. At that time, we didn't know about SLED. That's why it is not there. Sorry about that. But but we actually use slate. We actually use slate in this child. So how many of you are aware of slate? Then we will not go into the slate. If you are aware of slate, put your hands up. Yeah, so most of you are aware of slate. Slate is a same dialysis but done in a slow method. In a 9-month-old baby, it might be difficult to do slate in most of the institutions unless and until you are having the origin, like the what is that called? Pediatric tubings and 5008S. It might be difficult in doing a slate in this small child. But going back to team A, our last question, what are the conditions where CRRT has a definite advantage? What are the conditions where CRRT, yeah, over all three, CRRT, slate, PD. So anyone who would do hemodialysis in this child, intermittent hemodialysis, can put up the hand. Why? Why?
Child is very unstable on 2 inotropes.
Yeah. So that is out.
Of
So
question.
of the slate, CRRT, PD. So what are the conditions where I would say that I have a CRRT will be better than A? Do we have any guidelines for that?
When the child has cardiovascular instability or child is suffering from septic shock, in that case we can use CRRT is more preferable.
Okay, anyone can add one more? Team B is saying hyperammonemia. Anything else?
Cytokine removal.
Cytokine removal. Anything else? I'm not saying yes or no. These are the things that I am hearing. So hyperammonemia, cytokine removal, hemodynamic instability. What? Anything? Liver failure. Okay. And I was waiting for that. Increase in intracranial tension. So in the increased intracranial tension, I would definitely go for CRRT over slate. PD, I don't know. My personal.
Same, but within intracranial tension, you prefer CRRT simply because of the cardiovascular stability it provides. I mean, it's not that. Because if you've got a raised ICT, you don't want your blood pressure to go up and down.
Yes.
So it's ICT primarily because of cardiovascular stability it provides. Yeah.
PD, I don't know. My experience with PD for this sort of sick children usually has been what Anil just said, that you don't have the control. Sometimes you do good, but many a times you are not ultrafiltrating that much. The catheter goes this side, that side. So given the choice, I'll go for a CRRT in this sort of a child. Deblina, you want to add anything, or you can? Any comment? Any?
But are there any trials on SLED versus CKRT in raised ICP patients?
Yeah, in the adult there has been there has been RCTs in adult, and that have shown that you have a worse outcome if you are having a increased intracranial tension. Give him the mic.
Increased intracranial pressure. So one of the advantages of CRRT that you can adjust the osmolality in the blood, and this is all the time what's requested. So you don't. So we all the time in whatever in the dialysate, we increase the sodium concentration, so that we make the patient hyperosmolar, so you will not be herniation.
So Agni did mention like there's one of the two team did mention about the hyperammonemia. Yeah, hyperammonemia. Why do we prefer CRRT? Primarily because it gives a prolonged year. Often what we do is we initially have a more diffusion mode, or and then we can go for the slow.
But even like PD also can be done. So obviously, if you don't have CKRT, you can go for PD. And there were doubts regarding whether PD will achieve the same removal as CKRT. In that case, one can even consider continuous flow PD, like it is upcoming. If it works, then it can work fine.
Normal PD is not good for hyperemia, but half a lobe may be better than no lobe. We will conclude here, and we would like to say for all the PGTs and trainees who have also are planning to join the Pedicon, we have a full day workshop just focusing on the renal replacement therapy, and we would like you to invite you all there. So do register for it, and this is supposed to be a primer. This is supposed to be a sort of a primer or opener for that workshop, where we will be discussing all mode of RRT. I'll not go to the second part, which was like whether this child needs to be followed up, because I am sure now everybody, and including Agni, also says that the child needs to be followed up. Thank you.
Okay, thank you so much, sir, for the kind introduction. I also thanks to the whole ICH team for inviting and giving me the opportunity to talk. So I was thinking when the case-based discussion was going on, I was thinking my topic is going to be mess actually, because people are so interested about the giving Lasix or not, diuretics or not actually. That was there in the height of the moment. But let's see how to handle that part. So I'm just giving another opportunity if any PGs or other people is here to answer. So here the case is a 9-year-old boy with severe pneumonia and septic shock. And he received 40 ml per kg of fluid as a part of resuscitation. Now hemodynamically stable, but after 72 hours, he developed edema, increased oxygen need, and reduced urine output, that is 0.6 ml per kg per hour for last 14 hours. We calculate the fluid balance and found that 8% of positive balance is there, and creatinine is jump from 0.5 to 0.9 milligram per deciliter, and the chest imaging shows pulmonary congestion and mild ascites is there. So question is that what would be the next step of management? Can anybody volunteer to answer the question? Anyone please from the trainee or anyone? The enthusiastic people is gone. Dr. Ognisekhar, Dr. Sumantuda, all it is gone actually to ask them the question. So what would be the, this case is a bit clear from you. Who says the diuretics? Can you raise your hand? How many of you
think Rifa just said something, right?
Yeah.
Sir, Lasix?
So you want to give the diuretics because the topic is the diuretics in AKI, so you want to give the Lasix. Is that correct? So how many of you want to push the dose of Lasix in this scenario? Can you raise your hand?
So if the BP, the mean
I
arterial
think-
pressure is normal, then we can go for less.
Yes, BP is normal here actually. So I think majority is raising their hand to give a dose of Lasix. So I think you understand the picture where to give the Lasix. So in our scenario, for a treating pediatrician, especially when the patient is admitted in PICU, without calling a nephrologist, pediatric nephrologist, we feel that is like a blocked toilet, and it's like AKI. So you have a good plunger, that is a Lasix, and you're going to clean the block. Okay, so that's why it's found about 70% of the patients with AKI is given diuretics at the time of nephrology consultation or before starting off renal replacement therapy. So I think majority we are there actually. Take a chance. If open up, fine. If not open up, then call the specialist, because it's a difficult to get the nephrologist, especially the pediatric nephrologist. So now see the potential benefit of loop diuretics in AKI. It reduces the oxygen consumption in thick ascending loop of Henle. It's decreased breakdown of prostaglandin E2, thus increase the renal blood flow. It is flush the blocked tubule. Sometimes the ATN is just after the bolus of the Lasix, increase urine output and just starting clearing the blocked tubule. It many times it converts the anuric and oliguric AKI to non-oliguric AKI, and it also simplified the fluid management. So we are most worried about the intake output chart. So Lasix is going to be give a sort of solution there. But potential harm to cause by the diuretics, it decreases the renal blood flow through the renin and also decrease the GFR. If you give a long time, definitely it's going to be harm. It also acidify the urine. That's why the term Hirschfeld protein, there is a natural protein, is going to be aggregate and block the tubule. Definitely the Lasix and electrolyte imbalance, it's a very hand-to-hand situation, and the metabolic alkalosis would be there. Also, it can cause significant increased risk of ototoxicity, especially your kidney is not responding to Lasix and you're pushing again and again. So in that scenario, Lasix also not going to be clear from the body and is going to be damage your cochlear cell. And also impair the mucociliary clearance, especially when you're dealing with the case of respiratory and other systems. So now, Lasix can be used, diuretics can be used in 3 scenarios, like to prevent AKI, to manage AKI, or to predict the prognosis or progression of the AKI. This is the 3 scenarios we are discussing since morning actually, or the last problem-based discussion. We are stuck there actually, what to do or not to do. Let's see what's the evidence say as much as possible. Within a very short time of span, I try to figure out what the evidence can be get together. So for the prevention of AKI, the first review probably it's published in 2018, and they show the intermittent furosemide administration in patient with or at risk of acute kidney injury is a meta-analysis of around 28 studies, about 3,000 patients, but they found no difference in mortality because we are more worried about mortality that time, and there is no significant difference in the secondary outcome like urine output and progression of the AKI. And there is a significant improvement in the survival actually was found at the subgroup analysis. So they give some hope that the survival could be better. The next analysis 2020-22 that shows loop diuretics in adult intensive care patient with fluid overload. The last case we discussed about 70% of fluid overload. The adult data says that if you do the Lasix, and they review around 10 trial with fluid overload, 800 patient, loop diuretics versus placebo, and they found no difference in the all-cause mortality. But there is a few severe side effect, and they suggest need a further study to prove that hypothesis. So we are still confusing. Initial study shows survival benefits is there, but subsequent study with a big number still not matching. So in pediatrics, so these 2 analysis from the adult. Now I'm got a study from the pediatric, and that is done in India from the JIBMAR. Dr. Rohit is here actually probably. So he is one of the part of the study in this DM thesis from the JIBMAR. So what they did, they divided the 2 groups, trial of furosemide to prevent acute kidney injury in critically ill children. So it's a pilot study, and they give one group Lasix infusion and another group is dextrose infusion. And the furosemide group, but there is no, they found there is no significant difference in the both group to progress to the higher stage of AKI. And all-cause mortality even after 28 days was similar. So Lasix versus no Lasix, I think no, I mean there is no difference. Only there is some side effect could be there because of the extra Lasix. And this study actually probably the problem is that the small sample size 38, 37, and it's a pilot study. So still the answer is not clear from the pediatric groups. So now coming from the diuretics management in AKI, we have covered that prevention. There is a few studies shows there is some benefit in mortality, but not accurately. So how diuretics help in management of the AKI? So here is a meta-analysis review in 2007 that shows about 5 RCT, 550 patient, and they found no benefit on mortality and no benefit in renal recovery, but some benefit in shorter duration of renal replacement therapy, faster creatine fall, and higher urine output. So they also noted some side effect like transient tinnitus and deafness. So another review in 2010 published in, this is from the adult group. They want to show that prevention and treatment, we can see the progression of the record for the renal replacement therapy In prevention group, there is some shift of the diamond, but rest of the treatment group, there is no change in the outcome. Even if you can see the all-cause mortality, that is also in prevention and treatment group, there is no significant change. So this says that diuretics may modestly reduce the AKI risks, but did not improve the recovery or survival. And their use is limited to managing volume overload. They're more specific. If the volume overload is there clinically, then the LASIX could work. The routine use is not recommended by this review. So what the pediatric data exist? So this is the one of the study done retrospectively about 360 patients. They want to see the furosemide in management of acute kidney injury in pediatric intensive care unit. So it's a very sick patient. So primary outcome was the progression, the outcome of the renal recovery. So there is no significant difference. We can see the 28% versus 20%, but the statistically not significant. But the furosemide group has a higher urine output, but also some side effect like organ dysfunction, ventilation is a longer duration, and hospitalization was longer, and kidney recovery was overall kidney was also low, and no difference in the mortality, fluid balance, and kidney replacement therapy needed. So they conclude that did not prevent AKI progression and was linked to the higher morbidity and prolonged PSU stay. So they are little bit against the use of diuretics, but you know the retrospective study, there is not study design not so well to conclude the hypothesis. So now diuretics can be used as a predicting the AKI progression, because you have a kids admitted in PICU, you give the bolus, you want to know this child required hemodialysis or any form of renal replacement therapy or not, to make preparedness. So furosemide stress test. So since morning we just know the term and try to say what is that actually. So first it was described in 2013 by Dr. Chawla et al. It is that giving a dose of LASIX, 1 mg per kg IV. If the patient is already received LASIX, you can go for bit of higher dose, like 1.5 mg per kg, and look for urine output next 2 hours. In adult, this is if it is urine output more than equal to 200 ml per next 2 hours, that means FST is responsive. If it is less than 200, FST is not responsive. So what importance here? In pediatric, actually, we don't have a 200 ml is bit higher for the kids, so small kid. So in many studies, it took as a less than 1 ml per kg per hour, but few studies also took as a 2 ml per kg per hour as a response to the LASIX. So if the response to the LASIX, then the progression of the AKI is very less. But if it is response to the not respond to the LASIX, then progress to the AKI is very high. So I'm going to show the data. So FST can help identify which patients are likely to deteriorate, allowing the clinician to prepare for the dialysis and escalate the care. That is the helping point at the entry of the sick patient in PICU. So this is the Chawla study. They include around 77 subjects, and they found that FST could be a good predictor of progression of the AKI in next 72 hours or in longer. So this study is done from AIIMS Jodhpur by Dr. Alijah from the pediatric nephrologist. They did a prospective cohort study. So diagnostic accuracy of furosemide stress test and along with the cystatin C2 as a comparing agent for predicting the acute kidney injury progression in children. So what they included patient with stage 1 or 2 AKI and primary outcome to enter into the stage 3 AKI or requirement of the renal replacement therapy. So they include 41 children, and they found that at 2 hours and 6 hour urine output. So 2 hours 6 urine output after the LASIX, sensitivity is around 57%, specificity is around 100%. So, and also 6 hour urine output, sensitivity is around 70%, 1%, and specificity is quite high, is 100%. And they also show that the diagnostic accuracy of the FST is comparable to the urine and serum cystatin C. So I think the FST is coming for another guide, another biomarker to progression of the kidney injury or progression of the AKI stage. This is one of the study from the AIMS New Delhi by Dr. Bagga sir and Pankaj Hari sir and the team. So they did around 51, they look at the 51 patient. Those were like same AKI stage 1 or 2, and they gave a dose of Lasix, about same dose like FST protocol, and they found that around 9 patient out of 51 doesn't respond to the Lasix, and 8 of the 9 FST non-progressive groups develop stage 3 AKI, and 7 of the non-progressive group required kidney supportive therapy. See the percentage actually. So FST outperform, also they try to correlate with the NGAL and the procapaline, and they found that is quietly overperform with these other 2 biomarker. So they conclude that it's a simple, inexpensive and robust biomarker for predicting stage 3 AKI and need of kidney supportive therapy. So lastly, the Cochrane analysis in 2000, Cochrane review 2025. So what they include? They include all these adult RCT plus pediatric RCTs also, and they about 64 trial, 9,800 children patient, including these WHO regions from all these group, and they found that the diuretics to prevent AKI, it decrease AKI risks, it decrease kidney replacement therapy use, it decrease mortality with the low to moderate evidence, but no clear change in the serum creatinine and urine output they reported. And treatment as a diuretic as a treatment, the no reduction in the kidney supportive requirement, no improvement in the mortality, but there is a chances of hypovolemia, hypotension, increased arrhythmia because of the electrolyte imbalance, and minimum effect on hypokalemia and urine output. So they conclude that the prevention diuretics possibly modestly benefit, but evidence is low to moderate. Treatment diuretics no improvement in recovery or survival. The main role management of the volume overload, and to be cautious to monitor the hypotension, electrolyte imbalance, and the organ perfusion. So lastly, the KDIGO 2012, it's like more than 20 years right now. So that already says that not recommended to using diuretics to prevent AKI. They suggest not to use diuretics to treat AKI except in management of fluid overload. I think their statement still valid from the existing opinion. So my conclusion is that AKI in prevention may reduce incidence and need of kidney replacement therapy, but the evidence is low. In established AKI, no improvement in renal recovery, dialysis-free survival, and mortality. The primary role is managing volume overload. Routine use of AKI prevention and renal recovery is not supported by the current evidence. Thank you so much.
The next session was the biomarker session by Dr. Modi, but we'll be postponing it a bit, and instead we'll be having a talk by Dr. Yog McCarthy regarding his experiences in running a regional nephrogenetic service in New South Wales. And I would request Dr. Yog McCarthy sir to please come up on stage. He is a senior lecturer and pediatric nephrologist, Faculty of Medicine and Health in University of Sydney, Sydney Children's Hospitals Network. And sir has established a comprehensive national database of nephrotic syndrome in childhood. And he's the pediatric lead for renal genomics in New South Wales, Australia, co-lead for the Centre for Kidney Research Lab in West Mid, Australia, and also the founding member of KidGen, which is Australian National Kidney Genetic Research Collab. I would also request the chairpersons to please come over. Dr. Kaushik Mondal sir, who is the professor and head in the Department of Medical Genetics in SJPGI Lucknow. Dr. Dibyendu Rai Chaudhuri sir, he is associate professor of Pediatrics in Medical College, Kolkata. Dr. Otanupal sir, he is the associate professor in the Department of Nephrology in IPGMER and SSKM. And Dr. Meeta Paul ma'am, she is senior consultant pediatrician and pediatric nephrologist in Charitable Hospital and also Avni Women and Children's Hospital in Ranchi.
Okay, thank you for the kind introduction. I'm actually a bit disappointed because I wanted to hear the biomarkers talk. So hopefully you're not too disappointed by the end of this. So this was supposed to be the last talk at the end of yesterday, and I had rather envisaged that it was a nice way to round off the day. So if it feels a bit informal, it's not my fault. Okay, so 2012-13, I'd just finished my PhD in the UK in Bristol, and just got my first senior job. And at which point my family reminded me that I'd made a commitment to move back to Australia with my Australian wife, and raise our family in New South Wales in Australia, which is this highlighted in the dark blue. But I couldn't get a job as a senior staff because there just weren't any jobs available. So I was kind of twiddling my thumbs doing fellow jobs and decided to do a year in clinical genetics, which was an incredible decision and just really fortuitous. So recipient of right place, right time. So a year in clinical genetics, which followed on from some genetics I'd done in my PhD. And around the same time in the same place, Children's Hospital Westmead, our molecular genetics team were introducing the concept of next generation sequencing, and brought some machinery and technical expertise into the department. And because of this, we were then able to set up a renal genetics clinical service, which kind of began with the diagnostics and incorporated the a renal genetics specialist clinic. And the way we ran it at the beginning was very formal. Patient would see their nephrologist, and the nephrologist would refer on to this renal genetic clinical service. It was a multidisciplinary team, nephrologist, geneticist, and genetic counsellor. And there would be our MDT would have a meeting before the clinic, and then we would see the patient, and then we would have a meeting after, and the counsellor would be seeing speaking to the families beforehand and afterwards. It was all very formal, and we would then see them again, perhaps as a follow-up, and then refer back to their nephrologist. And it was great, and we really enjoyed it, but it was extremely intensive and not very efficient at all, and really not sustainable. And so fast forward 10 years, and what we got now looks very different. So a lot of the time, the nephrologists are seeing their own patients all the time, and they're sending off testing requests. And about half the time they're referring on to a renal genetics clinic, and the clinic looks very different. It's just myself and a senior genetic counsellor to keep me on the straight and narrow, and to do what they do best, which is fantastic and not easily replicated. We felt that having the geneticist and the nephrologist in the same room was actually just duplication, and maybe that's because I've done a year of clinical genetics and done the PhD, but I think you build that expertise actually. And so we thought, fantastic, we're doing a really awesome job. And about 5-8 years in, we thought maybe we should just ask our patients just to confirm that we're doing a really awesome job. And we did this qualitative study where we, someone not connected with the clinic, interviewed patients and families. And we found that actually it was really, really stressful for families and not as seamless as we thought it was. So families are very motivated for genetic testing, but they found the process very stressful, not least because of the waiting. It was long turnaround times. Even if they got a diagnosis at the end, it was a real emotional roller coaster, because most of the time we'd say, right, we found an answer for you, which is great. And they'd say, cool, what's the treatment? And we'd say, oh, no, we don't have any treatments for that. Sorry about that. And a lot of the time we were giving them massive amounts of information about the diagnosis, about the testing, about the potential outcomes, and then they would have to go home, digest that, often have to give that information to family members, and they found that very stressful as well. But they did tell us about things that they really valued. So they valued communication from someone they knew well, and that was interesting to us. So, you know, being sent to a new person to see them once or twice wasn't necessarily what they wanted. What we don't have a lot of in Australia, and I suspect you guys do it much better, is that we don't have a lot of patient support groups, perhaps because of our patient numbers are small and so spread out. And families really want that connection with other people going through the same thing. And they really like information resources, but not just verbal information download. So we're running a study at the moment. We've got a PhD student who's also a pediatric nephrologist who's looking at ways of, she's looking at kind of co-development of a clinical service which services the needs of our key stakeholders, including patients and families. And so we try to empower our pediatric nephrologists to order their own genetic tests in a safe and equitable way. And we do that by providing ongoing support. And this may be something you guys are already doing. This is just our experience. So we are, I think, first up, it's worth saying that in the same way that someone could become a specialist in transplantation or dialysis, CKD, taking on that genetics role is a big undertaking because there's so much genetics in pediatric nephrology. And so if you're the person that's got the genetics position, then you're kind of on call for these communications, these referrals all the time. And so constantly taking questions about families, what's the right thing to do here? How should we play this? And we also provide a kind of statewide online meeting once a month where we encourage clinicians to bring cases to that meeting, to present, ask questions, get advice, go back and do their own thing, or send on to the clinic. And we're developing information resources for clinicians just around guidance for testing. And one of the things we introduced, and this was probably more useful in the adult sphere than in the pediatric sphere, where I think pediatric nephrologists have a pretty good handle on a lot of the genetics because it's so integral to what we see day in, day out. We developed what we call a traffic light system, and this is a snapshot only. It's pretty comprehensive. We said, look, these are the things where you probably find just doing it yourself in your own clinic. So green for get on with it in your own clinic, that's fine. And then amber for maybe have a think about, does this require extra help, extra input from a genetic counselor or the wider team? And then red, we would say, look, that really needs to come to a renal genetics clinical service or even the clinical genetics service. So where you need a really urgent turnaround time, or patients are pregnant or family planning and there's more complexities involved, or really difficult social situations where how are you going to navigate cascade testing or segregation analysis, you're going to need some extra assistance beyond what you can do in your nephrology clinic appointment. You know, that's bearing in mind what time commitments people have. Around the same time we were developing all these things, we were extremely lucky, and there were some very strong advocates for funding. And in Australia, we have a national insurance program, and a lot of things are covered in the national insurance program, but genetic testing wasn't covered. And so that would be at the discretion of the hospital. The hospitals would have to pay for that. And so if we're trying to bring this into routine clinical practice, that was a big ask on the hospital. And I kind of slightly dread to think how much money we spent on genetic testing in the first few years before this coverage came in. But coverage for genetic testing for kidney diseases came in, started to trickle in initially with Alport syndrome, and then later on with everything else. And this was happening around the same time as some rebates for other genetic testing in other specialties, but we seem to be at the front of the queue, which was incredible and very empowering. And it does mean that there's that, we don't have to, there's no gatekeeping on genetic testing for suspected genetic kidney disease if they're seen by a geneticist or a nephrologist. And it's been worded in a slightly funny way, but there's a rebate for Alport testing, and there's a rebate for cystic non-Alport, and then there's non-cystic non-Alport. But it's basically everything else. Okay, and we provide some guidance around testing. We used to be really prescriptive, right? If you're thinking this is Barter's, just sequence the 3 or 4, 5, 6 Barter's Gittelman's genes. But nowadays we try and simplify it because otherwise it gets too complex. So these are the panels that we suggest people use. And if you think it's really hard sometimes to phenotype your patients, and so if you're like, well, it's maybe this, maybe that, and you're combining panels, that's fine. But if you're combining more than two, you might as well just order everything, which we refer to as the kidneyome. So that's all genes where there's a clear association with genetic kidney disease, and it's about 490 genes at the moment, maybe slightly less than that, I think. And we use this publicly available resource in Australia called PanelApp, and there's a different PanelApp in the UK, but the gene lists are curated by specialists throughout the country. And in fact, there's a number of these things happening all over the world, so including ClinGen, and there's a central body called the Gene Curation Collaboration, which is kind of trying to bring them all together under one umbrella so that we're not duplicating work. So that is freely publicly available internationally. You can find out what genes should be included in a genetic test. Where is there clear evidence for an association between the gene and the phenotype that I'm exploring? So these are really invaluable because it cuts out an awful lot of work. We still work very closely with our laboratory, so perhaps more so than we used to, because referrers, so nephrologists from around the state, are sending their patient's DNA and the consent form to the lab, and often the information that's provided, as many of you know, will be very brief, so FSGS or end stage, and so sometimes the lab come to us and say, is this the right test for this patient's phenotype? And we can review what information has been provided, and if we don't think there's enough, we'll go back to the referrer. But it allows us to have a little bit of oversight about what test is being ordered for that patient. And then the lab will also use us because variant analysis will chuck out many variants, and the scientists will go through those variants one by one to see if it fits the phenotype. And it's so much easier with a nephrologist who knows diseases, and we can go through that together. We bring different specialist knowledge, and it enables going through, filtering those variants a little bit faster. So nowadays, the extended model of care that we've got is we really value nephrologists ordering the testing on their own patients, because we understand that patients value that communication one-on-one with their own personal nephrologist, and that communication seems to be really strong, and the patients value it, and the clinicians have some autonomy over it, so they can order the tests. If they feel that they're out of their comfort zone, we can get involved, and we can work with the molecular genetics team in deciding what testing to do, and they'll involve us in variant interpretation and then return of results. If it seems like there's a complex outcome, then we can get involved at that point as well. So we are there if we're needed, and we can back off if we're not needed. So what actually is the prevalence of genetic kidney disease in the kidney clinic? This is really interesting. We looked at this where I tortured a couple of medical students to go through every single referral that came through to pediatric nephrology over a 5-year period. And we gave them a list of diagnostic criteria and said, these are the criteria that we would generally use as a starting point to decide whether to order a test or not. So for instance, steroid-resistant nephrotic syndrome or atypical HUS, yeah, you're going to get you should be offered a genetic test. So they went through that, and they did it over 5 years. And we have 2 hospitals in the children's hospitals in the state, and it was the same across the 2 hospitals, even though the patient cohorts that or populations that they serve are very different from multiple different viewpoints, including ethnicity and social economic status. But it was the same. 21% of all prevalent patients have a diagnosis that puts them at risk of a genetic etiology and could be offered a genetic test. So that's pretty interesting. That allows you to work out how many tests are you going to be offering each year. And if you then narrow that cohort down to children with CKD3 onwards, actually it goes up to about 60%. And then if you narrow it down to kids that have reached end stage, then you're looking at around 60% of those have a confirmed genetic diagnosis. That's pretty, that's pretty strong. So the genetic or the burden of genetic disease is reasonably high in our clinic, but actually ramps up considerably for children with more advanced chronic kidney disease. So we actually measured this. We just looked at the lab's output on all the families that have been referred to for testing, and we looked at sort of hit rate, and it's very phenotype dependent. So you'll see that for Alport syndrome, there's a pretty high hit rate, not surprisingly, but for Kakut, pretty low hit rate. Overall, for children, we got a diagnostic hit rate of about 45%, which is pretty reasonable. I think it's pretty equivalent to what's been found in other cohorts around the world. And that probably means that we're testing the right number of children. We then, that was a few years ago, it was about 5 years ago, then we started collating this on a national level and in children and in adults, and we combined that data, and this is sort of 5 years later, and we found that it's actually exactly the same. So still 45, 46%, which is interesting. So it hasn't changed, which is good. Okay, so whilst we're doing all this, there's a couple of other really big things going on around the world, and you've probably started to hear about this. Incredible technology that kind of still blows my mind a little bit. We're all used, particularly as paediatricians, we're used to newborn screening. We can see the value in it and how incredibly powerful it can be. Imagine that you take your blood spot card, you cut out the card with the blood on it, you then extract the DNA from that, and you run a whole genome. And so that is work that is being done similar to that around the world, multiple different sites and slightly different research projects, but they're trying to combine it so that there's a community of learning and output. So if you were able to do a whole genome on a newborn baby in order to screen for diseases, which ones would you screen for? And then obviously there's rules around, or not rules, there's advice around what constitutes screening, and you have to have some sort of therapeutic intervention that would be of any benefit. So which genes would you include from a renal perspective in that screen? It's an interesting ethical question and not easily answered. And you probably need to talk to patients as well as clinicians, other key stakeholders. Some of them are pretty straightforward: cystinosis, hyperoxaluria. Others are less clear, like X-linked Alport, should that be in there? Do you really have an intervention? Yes, you kind of do with an ACE inhibitor, but is it going to present in the first few years? Maybe not until 4 or 5 years. So would that qualify? And I think it's going to be different across different countries, but really interesting work. Another thing that we're seeing in Australia, and I'm sure is happening around the world, is preconception carrier screening. And we had a fantastic government-funded project that ran for a year, which showed that if you do it, you can roll this out completely highly automated. So it's rapid, high turnover, reproducible. 2 people want to have a child. They both get exomed, and the exomes are examined by computer software to see if the woman carries an X-linked variant that could be passed on, or if the 2 of them carry a variant in the same gene that puts them at risk of an autosomal recessive condition. And they'll only report pathogenic or likely pathogenic variants. They won't mess around with VU because it's too messy. And this showed the outcomes were really positive. High take-up rates, very successful. So then the government said, okay, well, we can provide a rebate for 3 genes, so SMA, Fragile X, and cystic fibrosis. So now that's a government-funded program. But if you want more than that, you have to pay. And actually, it's quite expensive. And people do want more than that. It's a really high take-up rate, but it's quite expensive. So if you want the expanded one for all of the genes that are recessive or X-linked, it's about $2,500 per couple. Okay, so what else is new? Well, we're starting to understand the importance of measuring the output or impact of genetic kidney disease. So we have an end-stage kidney registry that collects data every year on dialysis and transplant patients, and we've now started collecting data on genetics. So has your patient had a genetic test, and if so, did it all to the primary diagnosis? And that's going to be really informative for us. We're going to understand much better about the burden of genetic disease and end-stage kidney failure. We're also continuing to measure the outputs of the Renal Genetic Clinical Service, both in kind of quantitative as well as qualitative study. and we're starting to look at testing methods. So in Australia, because we don't have access to the reagents for whole genome sequencing, we use whole exome sequencing as backbone 99% of the time. And that's not great for all of our genes. So MUC1, PKD1, not well covered, MUC1 especially. So we're looking at, well, what are the other technologies that are going to be useful? And we understand that long read sequencing is going to be really informative for MUC1, and whole genome sequencing is really required for PKD1 to a certain extent. So if you're negative on an exome, but you've got a strong family history, you should be put into a whole genome sequencing. So we've got a research pipeline. We're lucky. We've got some government funding for a research pipeline, and we're trying to understand how best to use that technology. That's whole genome sequencing, long read sequencing, RNA-seq for potential splice site variants, increasing our sort of diagnostic hit rate. So finish up. Magic wand, how would I design a renal genetic clinical service? We put patient front and center. You have the laboratory, clinicians, specialists in the renal genetics, and a research team all together communicating, and you evolve and adapt as everything changes, which it continues to do. All right, I might just finish up there. A lot of people, 3 talks I've given, a lot of people I've got to thank for all the work that they've done, and happy to take any questions.
To go to the felicitation and second. So now we come to the last part. Where is Deblina? And the plus point is, the minus point is that very few people around. Very few people around. But the plus point is that you have now a very high chance of getting a prize. So that is the plus point, that you have a very high chance of getting a prize. So Deblina will proceed further with this.
So I'll just hand over the session to our quiz masters, Dr. Niladri Bose and Dr. Suchishmita Shaha. Both of them are very dynamic, very energetic, very talented. Dr. Niladri is now consultant pediatrician and pediatric nephrologist in Bhagirathi Neotia Hospital, Kolkata. And Suchishmita is senior resident in the Department of Pediatrics in AIIMS Kalyani.
Pretty fast because it's almost 5 p.m. All of us have to go back to our home. Okay.
Okay, so all of you are requested to take a blank paper, and it will be advantageous if you just note down 1 to 20. There will be 20 questions, and you will be allotted 15 seconds for each question. And on correctly answering one question, you will get 10 points. And if you are answering it wrongly, you will get a negative of -5. So it's better to mark only if you know and write down the answers. Once you jot down the answers, at the end of 20 questions, we'll take the papers and we can then check.
After the end of the quiz, I will come to each of you and I will collect this paper. So all of you have that paper and marked 1 to 20. And write your full name on the paper. Otherwise, we will not be able to identify who is the rank 1, 2, 3. Writing your name is most important. Otherwise, you have answered 20 correct and no name. So no prize to any anonymous person. So we'll read out the question. After that, the timer will start. The timer will start and you will write the answers. Say question 1, A, B, C, D, whatever the answer is. Okay. So are you all ready? Can we begin right now? Okay. So let's begin. Question number 1. A 9-month-old child, 10 kilo, with sepsis AKI started on PD for CCF with in volume of 30 ml, 30-minute cycle, 2.5% dextrose PD fluid. On day 2, you find out there is no CCF, blood urea is 90, creatinine around 2.1, sodium is 168 milliequivalent per liter. Day 1 value was 145, potassium was 3.9. What specific modification in PD fluid is required at present in this patient? And your time starts now. $15 seconds. After that, I will flip over to next question. Time's up. Next question. A 8-year-old boy is admitted with severe malaria. Serial values of serum creatinine shows rise from 0.7 on day 1 to 1.6 on day 3 of the hospital stay. Urine output is 1.4 ml per kg per hour. Serum potassium 6.3. What is the stage of AKI according to the KDIGO 2012 guidelines? And your time starts now. Time's up. Next question. A 9-year-old child in a tertiary care center with B-cell ALL is initiated on chemo using the standard protocol. On day 3, serum calcium is 6.7, phosphate 8.9, creatinine 1.1, uric acid 8.3, sodium 133, potassium 7.2, and urine output is 0.7 ml per kg per hour. BP is 118/72. The renal replacement therapy of choice will be, your time starts now. Just put the correct options only, A, B, C, D. Time's up. Next question. Which parameter is not included in the STARS score assessment for neonatal AKI? STARS score. Your time starts now. Time's up. Which of the following endotoxin removal devices is specifically designed for direct absorption of endotoxins, mainly adsorption, and is often used in critically ill pediatric patients with septic shock to reduce the systemic inflammation very fast? Your time starts now. Indicate the options only. Time's up. Next question, number 6. In the context of pediatric AKI, which of the following novel biomarkers is most specifically associated with tubular epithelial cell injury, especially in cases of nephrotoxic injury? Your time starts now. Time's up. Next question. Question number 7. During maintenance hemodialysis, you notice there is a sudden rise in transmembrane pressure. There is an alarm, which suggests probable. Your time starts now. Next, question number 8. Which of the following AI-based prediction tool has now been studied for early detection of AKI in pediatric patients? Your time starts now. There is a new generation AI. AI is now everywhere. Next question, question 9. A 2-year-old child on PD develops cloudy effluent, pain abdomen with fever. The fluid culture grows Candida paracalosis. Which is the immediate first line management? And your time starts now. Time's up. Question number 10, after which Dr. Suchimita will take over. Which of the following researchers is most prominently associated with large-scale epidemiological and biomarker studies in pediatric AKI, including the AWARE and AWAKEN consortia? And your time starts now.
Time's up. So we move on to the 11th question. Which of the following clinical trials primarily evaluated the impact of early detection and intervention on outcomes in neonatal AKI? The options are so time's up. The next question. Which statement best reflects the goal of the Ninja Initiative on pediatric AKI? And the options are time's up. 13th question. In neonates with moderate to severe hypoxic ischemic encephalopathy, a single dose of theophylline has been shown to prevent AKI. So what is the primary mechanism by which it prevents AKI? And the options are time's up. 14th question. In critically ill children, what does renal angina index RAI primarily assess? The options are moving on to the 15th question. A 9-year-old boy presents with cola-colored urine, puffiness of face for 2 weeks after a preceding episode of sore throat. Investigations show that serum creatinine is elevated. Urine analysis reveals RBC cast. Mild proteinuria, C3 is low, C4 is normal, and ASO titer is elevated. So which statement regarding his acute kidney injury is most accurate? Going to the 16th question, a 12-year-old with septic shock develops oliguric AKI. Renal biopsy shows tubular epithelial necrosis with granular cast. Which nephron segment is most susceptible to ischemic injury? The options are moving on to the 17th question, a 10-year-old boy on antibiotics develops AKI with fever, rash, and eosinophilia. What is the most likely cause? Time's up. So moving to the 18th question. All of the following are markers of damage from the injured kidney except Going to the 19th question, which of the following is a key advantage of the KDIGO definition of AKI compared to rifle and Akin? And now the final question. A 12-year-old girl presents with massive paraquat ingestion. She is hemodynamically stable but develops rising creatinine and oliguria. Lab shows hyperkalemia with metabolic acidosis. Which of the following is the most appropriate extracorporeal therapy to reduce the toxin load? So this brings us to the end of the quiz. We have put forward the 20 questions. Now we'll be collecting the papers, and while Dr. Niladri collects the paper and calculates the score, I will quickly discuss the answers. I think almost most of the questions can be answered if we have listened to the sessions from the morning, because all of them have been covered in the preceding discussions.
কটা পেজ দুটো give your name. Your name is torn.
Okay, so the first question was a 9-month-old child with sepsis AKI has been started on peritoneal dialysis, and we had given a peritoneal dialysis prescription for this particular child. And on day 2, we find that the serum sodium is 168, and on day 1 the value was 145. Potassium is 3.9, serum creatinine is 2.1. The initial fluid overload that was there has reduced significantly. The rise in sodium could have been due to sodium profiling, because the short cycle was initially preferred to reduce the fluid overload. But if we want to continue peritoneal dialysis at this point, what will be the modification that will be required? We know that the usual PD fluid that is commercially available has a sodium of around 130 milliequivalent per liter. So at a serum sodium of 168 milliequivalent per liter, if we do not modify the PD fluid, there will be chances of sudden drop of serum sodium. We do not want that, so we have to increase the sodium concentration of the peritoneal dialysis fluid that we are using. So answer will be A. The second question, this is a very straightforward question. We have discussed the KDIGO criteria definition for AKI and its stages a number of times throughout the day. So we can see that the serum creatinine has increased from 0.7 to 1.6. So it is more than 2 times the upper limit of normal, the baseline creatinine, because 0.7 to 0.7 to 1.4 would have been 2 times. So this would be stage 2 AKI. This third question, a case of B-cell ALL evidently is in tumor lysis syndrome. In a patient with tumor lysis syndrome who has also developed oliguric AKI, we would want rapid removal of the cell breakdown products. The child has not been mentioned to be hemodynamically unstable. So here probably intermittent hemodialysis will be the best preferred way to remove the cell lysis products from the blood. The START score, again, this has been discussed a number of times as a predictive criteria for AKI in neonates, and it includes a number of criteria like gestational age, use of positive pressure ventilation before shifting to the ICU, urine output, serum creatinine, but serum sodium level is not a part of this criteria in the START score. So this will be the incorrect option and the option for this question. Then which of the following endotoxin removal devices is specifically designed for direct adsorption of endotoxins? Among the 4, Torimixin basically has polymyxin B, and it has been specifically used to remove endotoxins in grossly infected patients with septic shock. So option D. In the context of pediatric AKI, which of the biomarkers has been most specifically associated with tubular epithelial cell injury? It's KIM1. During maintenance hemodialysis, we know this, that if there is a sudden rise in the transmembrane pressure when the dialysis had been functioning properly till a few times, after ruling out any kinking in the vessels, filter clot will probably be the most probable cause leading to rise of transmembrane pressure. Among the AI-based prediction tools for detecting AKI, among the tools that we had given, most of the tools have been basically developed in adult population. XGBoost has been a AI tool that has been studied and used in pediatric population. The ninth question, a patient on peritoneal dialysis developing peritonitis, and in culture it is evident that it is fungal peritonitis. We know that the ISPD guidelines suggest that in case of fungal peritonitis, we need to remove the PD catheter, start the patient on intravenous antifungals, and of course we need to shift to any another alternative variant of renal replacement therapy, so option B. Which of the following researchers has been associated with studies like AWARE and AWAKEN studies? We know that Stuart Goldstein, he is well known for his contribution in both this large-scale epidemiological studies, one of which was done in the adult population and other in the neonatal age group. Which of the following clinical trials primarily evaluated the impact of early detection and intervention on outcomes of neonatal AKI? This is the AWAKEN study, the largest epidemiological study in neonates. Which statement best reflects the goal of NINJA initiative in pediatric AKI? We know that NINJA was an electronic tool, nephrotoxic injury negated by just-in-time action. It was developed basically to reduce the risk of nephrotoxic drug-mediated AKI in hospitalized children. So it was a quality improvement program by using this electronic app. And so the main goal was to limit the nephrotoxic drug exposure. In neonates with moderate to severe HIE, single-dose theophylline has been discussed that it has been recommended to be used within the first 1 hour of birth in children with severe HIE. It basically inhibits the adenosine-mediated vasoconstriction, improves the renal blood flow, and thus has a role in preventing AKI. In critically ill children, what does renal angina index primarily assess? So we know that renal angina index has two components of risk and injury, and combining the components of risk as well as injury, that is fluid overload, rise of baseline creatinine, and the risk components together, it helps in predicting that which of the patients admitted have the risk of developing AKI over the next few days, and it is ideally assessed on day 3 of PICU intensive care unit admission. Question 15, this was a patient of post-streptococcal glomerulonephritis. We all know that here the AKI is mediated by, it's an immune-mediated glomerulonephritis caused by deposition of immune complexes by 2-3 proposed mechanisms and causes intrinsic AKI. 12-year-old boy with septic shock develops oliguric AKI, and here we have discussed that which nephron segment is most susceptible to ischemic injury. The proximal straight tubule, basically it has a high metabolic demand because it is associated with active reabsorption of multiple number of substances. At the same time, it lies in the medulla, which has reduced blood supply compared to the cortical part. So this segment is most susceptible to ischemic injury, and it's the S3 segment of the proximal tubule. 10-year-old boy on antibiotic develops AKI with fever, rash, and eosinophil It is not very specific, but it has been seen that acute interstitial nephritis may be having associated eosinophil. So among the 4 options, the best probable option would have been option A. Which of the following are markers of damage from the injured kidney? Again, this has been discussed in details today. There are markers of injury and markers of function, that is when the injury has already happened. While NGAL, KIM1, interleukin 18, all these are markers of damage. Cystatin and creatinine, these are markers of kidney function, so it appears later, the rise appears later. So option will be option B. Which of the following is a key advantage of KDIGO definition of AKI compared to Reifel and Akin? Again, so this has again been discussed. It combines the benefit of both the previous guidelines for defining AKI, both Reifel and Akin, and helps in early detection of AKI. It increases the sensitivity as well as specificity of diagnosing AKI. 12-year-old girl with massive paraquat ingestion coming to us with AKI along with hyperkalemia, metabolic acidosis. If you want to remove the toxins fast, the best method would be hemoperfusion, where we use a cartridge to specifically remove the toxins from the blood. So coming to the end of the 20 questions, I think we have the scores cards ready and we can have a discussion.
You people don't have any question.
So, well done, very well played, everyone. Answers has already been discussed, but definitely we have to announce the first three. But before we announce, I would like to know about your feedback, any comments, anything you want to share?
না ওদের কোনো কমেন্ট নেই, ওরা জাস্ট গিফটটা চায়।
Okay, so
any comment?
আরামসে
No.
বলতে পারো, কোনো অসুবিধা নেই।
Any
So, I
comment,
would
question?
like to request Jyoti ma'am to kindly hand over the prizes over here. So the second runner-up, although the scores were quite neck to neck, the fight was pretty good. So a big round of applause to all of you. So the second runner-up, Dr. Shantanu Jana, with a marks of 100, century. Well done, Shantanu. Shantanu from which? ICH, excellent. हाँ. The first runner-up with a score of 110. That's why I was telling it was a quite neck to neck fight. It is Dr. Bushra Alam. Where are you from? Which institute? SRICH.
Which institute?
ICH. So, sir is actually making them study the nephrology very well. Good. And now the winner with 120 points, Dr. Nikhil Gupta. Congratulations, Dr. Nikhil. Which institute, Dr. Nikhil? Currently you are in ICH. Excellent. So all the three prize backed by team ICH only. Excellent.
Question কি লিক হয়েছিল নাকি আগে?
I am not a part of ICH right now.
আচ্ছা, তাহলে লিক হয়নি।
Thank you. Thank you everyone. Thank you so much. Thank you so much.
Thank you very much. And just before going, because you are still there, you have to listen. Devlina will be giving the vote of thanks. Devlina, vote of thanks. Okay, I will give the vote of thanks. So thank you very much. First of all, obviously, I'd like to thank the Institute of Child Health for allowing this, and I would like to thank the Birmingham Children's Center and the International Society of Nephrology for the partnership. I'd like to thank all our faculty members from ICH who have worked very hard, and above all, Devlina, our organizing secretary, who apparently has not been sleeping for the last few days with the anxiety. And Deepanjana, I don't have to thank. Everybody knows that the heartthrob behind this is Deepanjana, and we are really, really grateful that we have got this association with her. I'd like to thank the external faculties who have come from abroad as well as from India, like coming so far off for such a focused CME. And I'd like to thank all the sponsors who have helped. And above all, I'd like to thank all the delegates who have come here for a focused CME. Ultimately, we did end up with having a sizable number of attendees for a CME which was on day one focusing on nephrogenetic, which even the nephrologist, 99% of them said that we don't understand, and on just on AKI. Thank you very much, and I'd like to close this.